There are 2 points I'd like to make. One is that oftentimes hospitals like to take the easy road. So instead of really getting into trenches and saying, yes, this is an infected patient or this is not, we should stop antibiotics, they may say, okay, we're going to restrict certain drugs and we're not going to restrict others. And that's sort of the backbone of how things are done. And that means that a drug like a fluoroquinolone or Piptazo keeps getting used empirically when it probably isn't necessary. The other point I'll make is that, there are simply patients that come into the intensive care unit where we can't help them. I mean, they're going to die regardless. And I think that becomes another area where stewardship may be helpful. I mean, why use our best antibiotics in a situation where we know there's really no hope for that person?
And to echo that, one of the fascinating drivers of antibiotic abuse in U.S. hospitals right now is the sepsis quality markers from the Centers for Medicare and Medicaid Services. And you can think CMS stands for that, but I think CMS stands for can't manage, and you can figure it out. But the point is, they basically, exactly, yeah. And they are saying, look, we want to see how quickly you're getting antibiotics on board. We want to look at your mortality rates for sepsis, and it's an effort at coding, right, and blah, blah, blah. But what it means is anytime someone, quote, is flag positive for sepsis in your EMR, all of a sudden these resources get mobilized, and the first thing that they do is they give the patient antimicrobials when it was probably just heart failure, or they were hypovolemic and they had a lactate from that, or they were underdialyzed. And the reflex is, because all of these syndromes look similar, well, since I'm getting dinged if I miss sepsis, we're going to overtreat sepsis. And
they also choose which agents you get to use, and it might go counterintuitive to stewardship principles.
And so this is destroying the value and the logic based on the evidence, because we have evidence in the ID literature that clearly says the tail end stewardship approach. Don't restrict at the front end, but clearly the benefit comes from restricting at the tail end. So you enforce narrowing, you enforce shorter courses of therapy. Restricting at the front end just causes harm. We have that literature. You pair it with the literature that Marin has developed over a career, really demonstrating that for severe infection, in the case of septic shock, the number needed to treat to save one life with appropriate antibiotic therapy is 5. 5. And we're arguing about this. It's absurd, while policymakers up here are trying to make benchmarks and dashboards that actually are causing active harm for our patients. And on this, I think pharmacy, ID, and critical care would all concur.
Even I, down in the trenches every day fighting with ID, I agree. How's that? You know what occurred to me as I was hearing all of you talking? We have to move on, but I do want to at least talk about this. We see critically ill patients, and as they reach end-of-life decisions, we have less trouble, it seems to me, cutting back on pressors or stopping them, because everybody sees pressors can be harmful, for example. We have a lot more trouble stopping antibiotics.
I think that's
even if they're not working.
I agree with you. People say, well, it's just an antibiotic.
It's just an antibiotic.
And Brad Spellberg, bless his heart, gentle soul that he is, had a great editorial, Piece of My Mind, in JAMA about a year and a half ago. And he goes, antibiotics are life-sustaining therapy. If you wouldn't offer vasopressors, why are you offering an antibiotic? Because offering the antibiotic is actually worse than offering pressors, because the antibiotic may prolong suffering and at the same time create resistance that's going to hurt someone else. And so I totally embrace that. There are patients who come into my ICU where we are limiting therapy, with or without the family's approval, and that will include not only artificial nutrition, but also antimicrobial therapy, because it's prolonging suffering. And I think you're seeing, at least in intensive care units, that attitude changing a lot. I think in oncology services, I don't see that happening at all yet.